So I feel like the doctor should have gotten my stone, but they didn't. I'm really, really frustrated. Let's talk about why this might have happened. Hey guys, Dr. Segal here. So the question is, does my doctor have an effort issue? They said they couldn't get to my stone and treat it. Why not? So we get this question very frequently, and I think it's worth talking a little bit about the nature of ureteroscopy, which is the scope or the technique that we use to get stones oftentimes out of the kidney and out of the ureter, which is the tube that drains urine from the kidney to the bladder. Obviously, patient's expectation is that they go in for a procedure, the stone is taken care of, and then it's all history. But there's a number of things that we see in there or we find in somebody's ureter or kidney that sometimes prohibit us from treating the stone in totality. So your urologist likely does not have an effort issue. There's a pretty good explanation why. So let's go through some of those right now. The first thing I tell people, and this is really common, is the caliber of the ureteroscope, the scope that we use to do the procedure, sometimes is bigger than the caliber of the ureter. All right. So if you look here, so this thing here is, this is your kidney, this is your ureter, okay? The tube that drains urine from the kidney down to the bladder here. This ureter, we use a scope to go inside of it and treat stones. The stones are on this side, but I'm just going to draw the size of the scope here. Now, you can see just by what I drew here, the scope is pretty darn big compared to the size of the ureter. Some people just have a smaller ureter than other people. If they have a smaller ureter than other people, we can't just force this thing in there. It's not safe to do that. What we have to do in that situation is we have to let that ureter get bigger over time. How do we do that? We place a tube from the kidney down to the bladder called a stent. That stent will usually widen the ureter over about 10 to 14 days. And then once that ureter is wider, now almost always we can get this scope up there because the scope is now a smaller caliber than the size of the ureter. So that's often one reason why we can't get to the stone on the first go around, simply because the caliber of the scope is bigger than the caliber of the ureter, and a stent over time can fix that problem, number one. The other reason why is sometimes we'll put this scope into the ureter and we'll start getting close to a stone. Let's say the stone is here, but we'll see signs in the kidney or elsewhere that, you know what, this stone might not be safe to work on. And when I say that, in this regard, I'm talking about infection. One of the things that can be really problematic when you do this type of surgery is if you start working on a stone that's infected, all right? It's almost like taking a bomb of infectious material and disseminating this into the bloodstream. And that can be very problematic and even put somebody in life-threatening circumstance. So sometimes what we'll do is when we look up there and we see the stone and we have an intention to treat it, and we'll see all this kind of debris around it, like all this kind of fluffy white stuff. And oftentimes we'll put the brakes on at that point and say, you know what? It looks like there's an active urinary tract infection here, even if we don't necessarily have a culture that's shown that. It just looks infected. And in that situation, a safer thing to do is to kind of get out of Dodge, put a stent in, allow the infection to clear, get another urine culture, make sure it's a sterile environment, then bring the patient back when we're sure it's a sterile environment, and then work on the stone. Everybody wants to get everything done around the first go around, but certainly you don't want to get admitted to the hospital and have kind of a life-threatening infection if we work on a stone that has a potential infection in it. So that's a second reason why we may not be able to treat the stone on the first go around, is signs of infection that prohibit us from completing the procedure. Another reason why is when we work on these stones, we are still using a big scope in a small space, okay? This is an unnatural thing to do on the face of it. And there's always a chance of trauma or damage to the ureter. So sometimes when we're working on this and we see that there may be a slight injury to the ureter, or the ureter looks like it's perforating, or there's anything dangerous at all for what we see intraoperatively, that's when we put the brakes on it and say, you know what, the safest thing to do now is to put a stent in, let this ureter heal up properly. And the ureter is very remarkable in that it can heal up pretty well after any kind of trauma to it. So leave the stent in, bring the patient back in a few weeks once that ureter is all healed up, and then work on the stone. And a stent is a fabulous device for kind of, quote, fixing ureters. So any trauma that we see intraoperatively will prohibit us from being able to treat the stone in totality, okay? So that's another reason why. The other reason why is sometimes we'll be really ambitious. If you look at this stone here, if this stone, let's say it's a bigger stone, let's say it's something like that, and we start working on it, all right? And we start applying lasers to it, and we start making it into fragments like this smaller one here. Well, over time, when we keep working on 30, 45 minutes, an hour, and it will start to look like a sandstorm. So if you take a stone and you take a jackhammer to it and you keep busting it up, you're going to get a bunch of gravel. When you're working on it in the kidney, that gravel doesn't always have anywhere to go. And so when it doesn't have anywhere to go, it can prohibit us from being able to see properly at the target. So essentially, instead of looking in a glass of clear water, it's now like trying to look through iced tea. There's just, the visualization is very obscured because of all these sand-like particles. So then when we see that, we can't see anymore. So we say, you know what? We have to put a stent in, bring the patient back once all that sediment has cleared out. Now that typically is for bigger stones, stones that are in the kidney that we're working on, because the stone has to be big enough to be able to create a sandstorm. So that's usually the circumstance where we see a situation where we can't treat the stone because of too much debris created by the stone itself. The other reason why, and this is actually a fabulous picture of it right here, is something that's called, the other reason why we can't complete a stone in totality, stone treatment in totality, is an impacted stone. So what does that mean? That means when we look up there, you know, one of the first things when we do these procedures, we put a wire past it. It's called a safety wire in the kidney, and then we start working on this stone. Sometimes that stone is so stuck in there that we just don't have any space to work. It's like trying to do a jigsaw puzzle in a tunnel, right? So it's just not enough space to work. And then when we have the scope up here, we're working on this stone, we're working on it, but we can't see all the aspects of it because it's so stuck in the ureter. So we can maybe work on part of it, but the rest of it is something we call impacted or stuck into the wall, sometimes even into the wall of the ureter. And in that situation, if we can't free it up, then what we have to do is place a stent, bring the patient back again because that stone was so impacted. Now, the good news with a stent in that situation is it makes a nice open space. So it can sometimes double the working space that you have in there. So when you look back in and you see that stone, well, now you have a nice opportunity to treat it because that space is much bigger, okay? The other reason why, and this is less common, is when we get these CT scans, you know, we will look at the ureter, which again is a tube. And sometimes in individuals, it's very difficult to distinguish a calcification that's inside the ureter versus just outside. Okay, so there are calcifications in the pelvis. We call them phleboliths. It's not important the name, but the point is that they're actually can sit right next to the ureter. They can be a calcification in vessels near the ureter. And the radiologist has a hard time distinguishing these two scenarios. Sometimes we have to verify it with a scope. And so when we verify it with a scope, we look up there and we don't see anything in the ureter because that calcification is actually just outside the ureter. So on occasion, we'll see calcifications that are outside the ureter that radiologists think might be in the ureter, but in actuality, they're, like I said, outside. Okay, and then this is kind of the parting shot, the thing I want you to remember as far as why it's so important and why it's important to you that the urologist didn't get the stone on the first go around. And the reason why is ultimately, and this is the thing that I want you to remember when they tell you they couldn't get to the stone, ultimately they've probably chosen a safer option for you by not treating that stone on the first go around for all the reasons I said. They didn't force a scope in there. They didn't work on an infected stone. They needed more space to work on an impacted stone. There was so much sandstorm in there they couldn't see properly. And so whenever a urologist does something like that, usually it's in your best interest that they didn't work on the stone. So that's the one concept I want you to remember. If you find out that the whole stone couldn't be treated on the first go around, is that you're probably going down a road of a safer option. All right. So I hope that's helpful to you guys. It's my pleasure talking about that with you. Please subscribe to our channel. We'd certainly appreciate it. Thank you so much for listening.